Okay, so hello, my name is Maya Truchel, and I am a high schooler studying in the USA. Today I will be presenting to you my work on the mitigation of pressure injuries through machine learning and an inertial wearable. So for the overview, I will be talking first about the introduction as well as the research objectives, and then go into more the database work and preparation, as well as the model building for AI and creating an inertial wearable, and then lead to the results and conclusions. So for an introduction, pressure injuries, they are also known as bed sores, and they occur when a part of a hospitalized patient's body is exposed to a prolonged period of pressure. And so these pressure injuries can occur in as little as 2 hours of continuous pressure, and they mostly occur over very bony prominences. So these injuries affect more than 2.5 million Americans annually, and they also caused for increased hospitalization and higher fees for hospitals, as well as increased morbidity and mortality, further increasing patient pain and causing for a higher probability of severe infections. So those severe infections would also require major surgeries. And so in addition, over 68% of elderly patients die within 1 year of discharge after a pressure ulcer related injury. And so right now, the incidence in the ICU setting is the highest, with up to about 38% of patients developing the injuries. And so on the right, you have an image of the stages of pressure injuries. So they range from anything from a pink spot on the skin, developing after about 2 hours of prolonged pressure, to anything such as rotting tissue and possibly even exposed bone in a deep tissue pressure injury. So although PIs or pressure injuries are influenced by mobility, activity, and sensory factors, right now the most widely utilized approach to estimating patient risk and preventing these pressure injuries is the Braden scale. However, the Braden scale is very subjective and has insufficient predictive validity and very poor accuracy in discriminating intensive care patients at the risk of pressure ulcers developing. And so additionally, none of the risk assessment scales were developed especially for use in an ICU or intensive care unit, where patients are more likely to experience the need for repositioning due to the high prevalence of pressure ulcer development. And so currently, medical and household devices have been developed with the intent to solve the problem of the prevention and treatment of pressure injuries. And so these specialized devices are things such as beds, overlays, or mattresses, and they've been designed to mitigate the health risks of bed sores and PIs. However, these types of mattresses work on pumping up or making different points of the bed higher or lower, in doing so shifting the weight of the patient instead of having to manually turn the patient to a different position, which is now very commonly utilized because of the fact that there's a higher need for healthcare professionals due to COVID and things like that. So right now, there are no uncertainties regarding the effectiveness of these support surfaces for preventing and treating pressure injuries. However, most of these approaches are too expensive or cumbersome to be provided to every ICU patient. So for the research objectives, we wanted to create a model that would predict predisposition to pressure injuries, and this would require complex sets of clinical features, not including wearables that would monitor the patients. So is it possible to create a model to determine predispositions to pressure injuries and utilize wearable device data to continuously monitor the patient and inform healthcare personnel of the need to move the patient to prevent these pressure injuries? And so the goals were to develop a model that will identify ICU patients with predisposition to pressure injuries based on clinical features available within the first 48 hours of admission. And then we would develop a low-cost device that would further prevent these pressure injuries that could be given to those most at high-risk patients. And so the functionality, we wanted to demonstrate the effectiveness of the clinical feature model for PI predisposition. And we also wanted to demonstrate the accuracy of an inertial device that we created and or images for the prevention of pressure injuries. And so this would rely only on clinical features available within 48 hours from admission. And this full system, along with the wearable device, should be able to handle various bed positionings and night and day situations for patient position tracking. So a two-prong approach of data modeling and a wearable was utilized as an integrated prevention system to assist against pressure injuries. So ICU patient data was retrieved and aligned into one data set using SQL query and join tables. And so this data was then able to be statistically analyzed and applied to K-neural network, logistic regression, and decision tree models for further training and testing of a model. And so a wearable device was then able to be utilized. It consists of a microcontroller-based system that is to be worn on the chest and sternum area. And this would allow for the capturing of patient positioning data. And so on the right is a data flow of the integrated system. So the MAC address, gyroscope, and accelerometer are provided by the microcontroller. And so this data is passed to a PHP script on a Raspberry Pi web server and is then stored in a PHP database. So my system, along with the gyroscope and accelerometer data, is able to send push notifications to a mobile device that sounds an audible alert for healthcare professionals, signaling that a patient has been in a singular position for too long. And so this audible alert could also be put into, say, beepers or any other devices that healthcare workers may have to basically assist them with the knowledge that they need to give attention to a patient. So the Mimic3 database is a very publicly available and credentialed database, and it contains de-identified records of over 38,000 distinct patients, and there are 58,976 admissions to an ICU between the years of 2001 and 2012 at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And so this data set is housed at MIT, and it's over 3 terabytes in size. It includes demographics, vital sign measurements, test results, procedures, medications, and clinical notes. And this is in more than 26 tables of data. And so right now, it was our goal to utilize only the variables that can be obtained within the first 24 to 48 hours from admission. And so this allows for timely interventions, but does not rely on doctor clinical notes. And so only the patients whose hospital stay lasted at least 48 hours and who reported pressure injuries in their demographic bucket were included and matched with their negative pressure injury patient cohorts. And so this left a total of 25,733 admission pairs to identify and extract structured features from the original tables for a total of 23 extracted features, as you can see down on your bottom right. And 1,483 of these patients acquired a pressure injury and over 24,000 did not. So the data from the multiple files or tables was joined by hospital admission ID and stored in a comma delimited format. So a total of 4 features were removed from the data set before machine learning was applied. So this would be date of birth, chart year, subject ID, and hospital ID. And so an ulcer label variable was added with a 1 representing a positive or present pressure ulcer diagnosis and a 0 representing a negative pressure ulcer diagnosis. And so machine learning requires that a data has no missing values. And so this gives us the option to remove records that are missing value or to impute the values from the remaining records. And so instead of removing the records, I removed the 5 features that had more than 50% missing records. And then for the rest, I utilized imputing in order to basically make sure that the data set was not swayed and to utilize the feature's median value. And so the categorical labels were then replaced with a one-hot encoding approach, which creates new features or columns based on the categories of the existing variable. And this drops the previous version of the variable. So this gives us 8 additional features for our data set with a total of 24 features plus the predicted category, which was that 1 or 0 Boolean variable for the ulcer. And so since some of the different features have a varied range of their maximum and minimum values, the variables were normalized to a 0 mean to prevent an individual feature from being over or underweighted, and to further generate interpretable and reliable predictions. So the data imbalance can be an issue for the classification task, since only 1,483 of the records are positive and more than 24,000 are not. So this imbalance was addressed by reducing the set of negative records with a cluster centroid approach to replace the original samples by the centroids of the clusters from the original data set. And so the new data set now has 1,152 positive pressure ulcer records and 1,152 negative, so an equal number. So to review, I utilized the complete Mimic3 dataset and minimized and simplified it to 24 features. Through the target pressure injury or no pressure injury variable, I created a training and testing sets to train my machine learning model to identify markers that would cause a patient to have a pressure injury or not. And so to evaluate and compare these classification models, we identified the k-nearest neighbors, logistic regression, and decision tree classifiers as the 3 most widely utilized approaches. And so we decided to compare these models using cross-validation, being iterated, the scaled training data features without the PI label and the pressure ulcer labels as the targets. And so the accuracy of the model, F1 score, the precision, recall, and the support are used to evaluate our results. So here is the inertial wearable that we created. It is based on a microcontroller, gyroscope, accelerometer, a voltage regulator, and other battery components that are soldered and connected with the prototyping board. And so the microcontroller is connected to the accelerometer that captures the data of the inertial movements and positionings of the patient. And so the microcontroller collects these gyroscope accelerometer values, sends them using Wi-Fi to a PHP script on a web server hosted on a Raspberry Pi Zero. And so the accelerometer indicates the patient's orientation, while the gyroscope indicates the patient's rotational motion. And so the PHP script then receives all of this data and inserts it into the database to allow for additional processing of how long a patient has been in a certain position. And so this would rest on the sternum area of a patient with a Velcro strap around their torso. And currently this is our first prototype. However, we are working towards minimizing it onto a custom PCB for even less invasive properties to the patient. So the accelerometer on the wearable device shows the positioning of the patient's torso, and the gyroscope indicates whether the patient is moving, and if so, at what rate. So these are the 6 most common body positionings in hospitalized patients. And so each position shows examples of how the accelerometer detects vectors of the patient's positionings. So this is in X, Y, Z through the 6 most common positions. So demographic and clinical features for the pressure injury and non-pressure injury populations in the MIMIC database. So several features have a large percentage of missing values. For example, troponin is missing 80% of their records. Albumin and total bilirubin are missing for more than 60%. And so continuous variables were compared using a 2-sample t-test, but none were found to be statistically significant through data analysis. So this slide shows the cross-validation accuracy scores for training and test data sets. And so on the left, logistic regression achieved the best average accuracy, followed by KNN, but the K-neural network was utilized for its ability to easily utilize the size and type of data we were training. And so on the right, you have a confusion matrix on the KNN test data set. It achieves the true negative score of 85% and true positive of 98%, giving information to calculate the precision, recall, F1 score, and accuracy. And so the KNN algorithm gave an average F1 score of 91% and a negative predictive value of 97.9%. So in conclusion, this research presents a machine learning model based on the MIMIC-3 public healthcare dataset in identifying ICU patients at highest risk for the formation of pressure ulcers. And so using features available within 24 to 48 hours of ICU arrival of patients, we can now identify those that are at highest risk for developing pressure injuries. And once those high-risk patients are identified, increased attention is directed towards them, and the intervals between rotations by the nurses are shortened. So alternatively, these patients can be equipped with the inertial wearable we created to provide healthcare providers with audible alerts and notifications when these patients must be turned or given attention to prevent development of pressure injuries. And in creating a wearable inertial device that includes a gyroscope and accelerometer, the patient's position in time is identified and tracked. In the future, goals will be to assess the wearable device in a clinical setting and to minimize it to make it even more non-invasive for the patient and to reduce power use. And so steps will also be taken to expand functionality to other settings, as well as retirement homes where pressure ulcer development is greatly prevalent. So here are my references. Thank you so much. I will be happy to answer any questions.